Welcome to the debate. Today's discussion is brought to the listener by Whole Life Healthcare. And I have to say, if our deep dive analysis of WPW syndrome got your heart racing, today's discussion on cardiac rehabilitation should keep your pulse in perfect rhythm.
That's certainly the goal.
Right. So today we are examining a fundamental shift in cardiovascular care. We're asking a central question. Is home-based telerehabilitation for post-acute coronary syndrome patients truly as effective as supervised in-clinic rehabilitation programs?
It's a critical question, mostly because the stakes for secondary prevention are just incredibly high. I mean, traditional center-based cardiac rehabilitation is an absolute cornerstone of recovery. We know definitively that it reduces cardiovascular mortality by an impressive 26%.
Anywhere between 17 and 39%. We are talking about patients who survive a cardiac event, they get prescribed this life-saving rehab regimen, and, well, they simply stop going.
Right.
And it is primarily due to logistical friction, transportation difficulties, scheduling conflicts, the exhaustion of the commute, or just financial constraints. So my stance today is that home-based telerehabilitation matches and sometimes even exceeds the clinical outcomes of in-person care while significantly boosting patient adherence by entirely removing those barriers.
And I'll be arguing that pure home-based models lack the supervised intensity necessary for complete risk factor control. Furthermore, equating remote attendance with genuine patient engagement, it masks critical clinical nuances that only an in-person physical environment can truly address.
Let's start by looking at the reality of the data, because the empirical evidence overwhelmingly supports the non-inferiority of telerehabilitation. When we look at the highest levels of medical evidence, the numbers are unequivocal. Take the Cochrane review on this topic. This isn't some small pilot program, it's a massive analysis of 23 different trials encompassing nearly 2,900 participants.
The gold standard for systematic reviews.
Exactly. And this exhaustive analysis found absolutely no difference in total mortality or exercise capacity between home-based and center-based programs up to 12 months of follow-up. But what it did find was a marginally higher completion rate for home-based care. When you remove the friction of getting in a car and driving to a clinic, patients actually finish the program.
Look, I hear you on the scale of the data, and the attendance boost is undeniable. But we need to take a hard look at what happens once they are actually, attending.
Well, let's look at the functional output of that attendance. A recent preprint study compared pre-COVID inpatient rehabilitation to COVID-era telerehabilitation. They tracked final exercise capacities using metabolic equivalents, or METs. And to give our listeners some context, 1 MET is the energy you burn just sitting perfectly still.
Right, and pushing up to 9 METs is roughly the equivalent of a slow jog or, say, carrying heavy groceries up a flight of stairs. It requires significant cardiovascular exertion.
Perfectly said. And in this study, the inpatient clinic group achieved 9.03 METs, while the home-based telerehabilitation group achieved 8.98 METs. I mean, they are virtually identical. And what makes that even more remarkable is that parity was achieved despite the tele-rehab group having a significantly older age profile. The functional gains are there, the safety is there, and the accessibility is vastly superior.
I come at it from a different way. We have to rigorously challenge how we are defining effectiveness. What happens during the session matters significantly more than a patient simply logging on and being marked as present on a digital roster. If we look at the Pagliari meta-analysis, a crucial limitation of remote care emerges very clearly.
You're referring to their distinction between hybrid models and pure remote models?
Exactly. The data shows that hybrid models, which they label CRH, where patients mix clinic visits with home sessions, successfully reduce total cholesterol compared to conventional interventions. But pure home-based telerehabilitation, or CTR, did not show that same reduction. This indicates a distinct lack of supervised intensity in pure remote models. Beyond just the physical output of METs, we have to look at cognitive and psychological involvement.
But isn't a patient inherently engaged if they are achieving those functional exercise capacities?
Not necessarily in the way required for comprehensive recovery. Consider the OPEN dataset, which stands for Older Adult Patient Engagement. This research illustrates the extreme complexity of measuring true engagement remotely. The researchers mapped out how affective and behavioral states fluctuate rapidly, sometimes every 1 to 5 seconds. These are incredibly subtle nuances. A flat screen often misses a fleeting moment of confusion or a sudden drop in cognitive investment. A clinician in a physical room catches those microshifts instantly and adjusts the therapy or the education in real time.
That's an interesting point, though. I would frame it differently. You bring up the intensity of the physical output and the lack of risk factor control in pure remote settings. So let's focus squarely on those functional gains and how technology bridges that gap. A network meta-analysis of 46 randomized controlled trials specifically looked at how telehealth interventions stack up against traditional care.
That's a massive slice of the literature. What were the specific endpoints?
It demonstrated that telehealth reliably improves VO2 peak, which is the maximum amount of oxygen your body can utilize during exercise, and the 6-minute walking distance. But the study gets much more specific than just giving a general endorsement to telehealth. The analysis revealed that combining wearable devices like smartwatches or heart monitors with smartphone applications is highly effective. In fact, it achieved a Sucre score of nearly 87% for improving that VO2 peak.
And just to ground that for our listeners, the Sucre score, the surface under the cumulative ranking curve, is essentially a statistical way to rank different treatments, right? Meaning that if an intervention scores an 87%, it is highly probable to be the absolute best option among all the treatments analyzed.
Exactly. It's effectively giving wearable integrated telehealth top marks. The wearable device acts as the clinician's watchful eye. It provides the objective physiological data necessary to ensure the patient is working at the appropriate intensity. The technology effectively replaces the need for a clinician to be physically standing next to the treadmill.
That's a compelling argument. But have you considered the psychological limits of exercising alone, even when you are wearing a state-of-the-art device? Let me return to those Pagliari review findings because they strike at the absolute heart of cardiovascular secondary prevention. Pure Tele-Rehabilitation showed no superiority in controlling triglycerides, LDL cholesterol, or systolic blood pressure.
And you attribute that entirely to the lack of a physical presence?
I attribute it to human psychology and supervised intensity. In a clinical setting, a physical therapist can safely push a post-acute coronary syndrome patient to higher intensities, say 70 to 85% of their peak heart rate. The patient allows themselves to be pushed because they know they are in a highly controlled, safe environment. If they feel a sudden chest pain or shortness of breath, emergency medical support is immediately available.
So you are suggesting that at home, patients are essentially holding back.
Exactly. At home, alone in their living room, patients self-limit, and it is completely rational. Out of an abundance of caution and a very understandable, profound fear of triggering another cardiac event, they simply do not push themselves to the aerobic threshold required to optimally modify those specific lipid profiles. A smartwatch can vibrate and tell you your heart rate is too low, but a piece of plastic and glass cannot provide the psychological safety net required to confidently push past the trauma of a recent heart attack.
I see why you think that, but let me give you a different perspective on the reality of the patient population we're dealing with. You are comparing an idealized, high-intensity clinic session to a home session, but that clinic session only matters if the patient actually shows up. We are facing a severe adherence crisis in traditional models.
But is a poorly executed home session better than a missed clinic session?
The data says it's not poorly executed. It's highly consistent. That same network meta-analysis I referenced earlier showed that smartphone apps combined with instant communication tools are incredibly effective at keeping patients in the program. They achieved an adherence Sucre score of over 74%. We have to look at the behavioral reality here. A slightly lower intensity session that a patient actually attends 3 times a week is vastly superior to a high-intensity clinic session they skip because they couldn't arrange a ride, or because the weather was bad, or because they couldn't take time off work.
But we are trading optimal clinical care for mere convenience.
We are trading perfect, but often inaccessible, clinical interventions for highly effective, highly accessible daily habits. The home-based model democratizes access to life-saving secondary prevention, and as the preprint study showed with the virtually identical 9 METs improvement, that daily habit yields equivalent functional capacity. The patient might not hit 85% of their max heart rate on a Tuesday, but they are doing the work on Tuesday, Thursday, and Saturday, instead of dropping out in week 3.
I'm sorry, but I just don't buy that. Let me tell you why. Equating basic attendance with true engagement is a dangerous oversimplification in rehabilitation. Let's pivot to the psychology of virtual learning, relying on the findings from that open dataset I mentioned earlier.
The study looking at the microfluctuations in patient states?
Yes, true engagement is not a binary state of being logged in or logged out. It has affective, behavioral, and cognitive components. The open researchers analyzed over 35 hours of virtual cardiac rehab data using human experts to label the footage. They found something fascinating. The most frequent state transitions occurred between being off-task and on-task, specifically when patients felt calm or satisfied.
Meaning they were comfortable but completely checked out of the actual rehabilitation process?
Exactly. Logging into Microsoft Teams or Zoom does not mean the patient is actively engaged. We've all been in virtual meetings where someone looks perfectly calm, nodding at the screen, but we know they're actually reading their emails or browsing the web. Patients easily slip into that exact same passive viewing during Tele-Rehab. They are present, but they are not absorbing the lifestyle education or actively participating in the movement correctly.
But surely an observant clinician on the other end of the video call can spot a patient who is zoned out.
That is where the data gets really concerning. The open dataset revealed that affective engagement annotation is highly subjective. They measured this using inter-rater reliability scores, like Krippendorf alpha. To translate that out of statistical jargon, it's basically a measure of how often two experts looking at the exact same footage agree on what the patient is feeling.
And the experts disagreed? Frequently. The scores were notably lower for affective, emotional states compared to basic behavioral states like, is the patient sitting or standing? Think about the implications of that. If a trained human expert annotator, meticulously reviewing and rewinding video footage frame by frame, struggles to accurately read a patient's emotional and cognitive state through a webcam, how can we possibly expect a clinician managing a grid of 6 different faces on a live compressing video call to do so? The nuance is entirely lost in the medium.
I'm not convinced by that line of reasoning because it drastically underestimates both the capability of the patients and the rapid evolution of the technology supporting them. Let's address the demographic reality first, because there's an underlying assumption here that older adult patients cannot effectively engage with or benefit from telerehabilitation environments.
It's not that they can't benefit. It's that the cognitive disconnect is higher through a screen for a demographic that didn't grow up with this technology as a native language.
But the preprint study specifically highlighted this exact demographic. The mean age of the Tele-Rehab group was 66.5 years old, and the cohort included patients up to 85 years old. Yet, they achieved an equal improvement in exercise test workloads compared to the younger, pre-pandemic inpatient groups. They are mastering the interface and doing the work. The results speak for themselves.
I don't dispute their ability to click a link or follow a primary physical movement. I dispute the system's ability to monitor their deeper cognitive engagement.
And that is where the technology is evolving rapidly. Regarding the difficulty of reading engagement through a screen, the open study itself proves that artificial intelligence is closing this gap. The researchers demonstrated that machine learning models can achieve up to 81% accuracy in recognizing engagement states using facial, hand, and body landmarks.
Using computer vision algorithms?
Precisely. They use extraction tools like MediaPipe to map the physical posture and facial expressions of the patient in real time. We aren't just relying on a clinician staring at a pixelated video feed and trying to guess who is paying attention. We are moving toward a paradigm where AI assists the clinician by monitoring these micro-level behavioral and affective shifts, alerting the clinician with a prompt when a patient's cognitive engagement drops. It acts as a digital co-pilot.
That's a fascinating vision of the future, and I am certainly not opposed to innovation. However, it is scientifically perilous to deploy these tools without acknowledging their massive glaring blind spots.
You believe the AI is currently inadequate for clinical deployment?
Let's look at what the AI is actually learning from. The open researchers themselves raise a critical caution. Almost all existing public engagement data sets, such as DAISY and EngageNet, which are heavily used to train these models, are based on young, healthy university students doing 10-second offline tasks like watching a short recorded lecture.
So the training data is demographically skewed.
Skewed is an understatement. Applying machine learning algorithms trained on the facial landmarks and behavioral patterns of healthy 20-somethings to 70-year-old cardiac patients sitting in their living rooms is fundamentally flawed. Age, physical health conditions, fatigue, and mental stress completely alter how affective and cognitive engagement are physically expressed. A 20-year-old zoning out looks very different from a 70-year-old experiencing mild angina or cognitive fatigue from cardiovascular stress.
Which is precisely why datasets like OPEN, which specifically target older adult patient populations, are being developed. They are actively correcting that blind spot.
It is a fantastic first step, absolutely. But it also highlights the profound complexity of the challenge. Remember, participant state shifted every 1 to 5 seconds. Until artificial intelligence can reliably and accurately measure true cognitive engagement in older adults across these rapid microtransitions, without generating constant false positives, the in-person clinician remains irreplaceable for optimal recovery. A clinician in a physical room doesn't just see a facial landmark mapped by media pipe. They read the posture, they hear the breathing rate, they sense the tension in the room, and they notice the subtle hesitations that indicate a patient is struggling to grasp a vital piece of lifestyle education about their diet or medication. You cannot digitize the instinct of a seasoned physical therapist.
Those are valid concerns regarding the training data of current AI models, and it certainly underscores why targeted datasets like OPEN are so vital to the future of the field. However, to summarize my position, the ultimate goal of secondary prevention is to reach as many post-acute coronary syndrome patients as possible and provide them with a structured, effective pathway to recovery. We cannot let the perfect be the enemy of the good. The empirical data, from massive Cochrane reviews evaluating thousands of patients to real-world network meta-analyses, confirms that home-based telerehabilitation democratizes access to life-saving care without sacrificing functional gains. By utilizing wearable devices, smartphone applications, and remote monitoring, we can bypass the devastating 39% dropout rates of traditional models. We are trading the theoretical perfection of the clinic for the practical, proven reality of consistent, home-based adherence.
And to summarize my perspective, while I certainly recognize the immense value in improving logistical access and raw attendance numbers, we cannot pretend that a purely remote model is a perfect substitute for the clinic. Pure telerehabilitation fundamentally lacks the supervised intensity required to confidently push patients to the physiological thresholds needed for comprehensive risk factor modification, particularly regarding vital lipid profiles. Furthermore, as the data on virtual learning psychology explicitly shows, logging into a session does not equal genuine cognitive and affective engagement. The nuances of human interaction, the rapid micro shifts in emotional states, and the profound psychological safety net provided by a physical therapist in a controlled environment are elements that current technology, including emerging AI models, simply cannot fully replicate.
It seems we have illuminated a fascinating tension between the necessity of broad accessibility and the requirement for clinical intensity. However, as we look at the spectrum of care, there is a distinct point of convergence in the data we've discussed today. Hybrid cardiac rehabilitation, or what the Pagliari meta-analysis labeled CRH, might represent the ideal synthesis of both our perspectives.
I would agree with that completely. Think of it like training wheels for cardiovascular recovery. A hybrid model where a patient starts their journey in the physical clinic allows them to establish a safe, physiological baseline. They build their confidence, they learn the correct form under direct supervision, and they experience what that required clinical intensity actually feels like without the fear of a medical emergency.
And once that baseline and confidence are established, they transition to a home-based technological model for long-term adherence. It beautifully bridges the gap between our two positions. It combines the psychological safety net and nuanced education of the in-person clinician with the logistical brilliance and convenience of remote monitoring and daily habit formation.
It utilizes the best elements of both environments to serve the patient comprehensively.
We want to remind the listener that there is much more to explore within the source material regarding these shifting rehabilitation models, the intricacies of the Cochrane reviews, and the fascinating AI datasets driving the future of cardiovascular care.
Absolutely. You can find our show on Spotify, and we encourage the listener to click the like or subscribe button to be notified of new weekly content as we continue to break down these complex medical advancements.
We also highly prompt the audience to comment on the show to receive a response that is exclusive to them, just like Dr. K got with our WPW syndrome debate. Your insights and clinical experiences enrich these discussions immensely. We will leave the final judgment on today's discussion to you, the listener. Thank you for joining us on The Debate.